Hello everyone. Today we will discuss the systemic manifestations of Hansen's. Systemic manifestations occurs most commonly towards lepromatous pole. The organism disseminates to the internal organs through the hematogenous route during the phase of basilemia. The early therapy halts the progression of systemic involvement. Basilemia and leprosy. Taking nasopharyngeal route as the main gateway by the inhalation, the bacilli quickly migrates to the cooler areas of the body with a temperature less than 37 degrees centigrade, accounting for the skin, peripheral nerves as the predominant sites of the disease manifestations. In multibacillary disease, the bacillary system to override these preferences and occupy the warmer sites too. In some cases, histopathological studies demonstrate the presence of bacilli within or between the epithelial cells of the nasal mucosa, suggest this to be the possible site of entry of the bacilli into the bloodstream. An important pathological observation in lepromatous leprosy is the invasion of endothelium of blood vessels and lymphatics by Mycobacterium leprae, which account for the further spread of infection. The study of Mycobacterium leprae genome has led to identification of surface proteins called adhesins that appear to play predominant role in the dissemination by helping attachment of the bacilli to the Schwann cells and endothelium cells. The bacilli disseminate into the almost every part of the body, apart from the skin, peripheral nerves. The tissues that shows a significant infiltration resulting in clinical manifestations includes the bones, eyes, upper respiratory tissues, kidneys, liver, and testes. Clinically significant sites are skin, peripheral nerves, bones, eyes, nose, oropharynx, testicles, and may be clinically significant are joints, kidneys, larynx, liver, lymph node, muscles of face and limbs, tongue. Clinically insignificant are autonomic nervous system, cardiac and respiratory systems, breast, central nervous system, endocrine organs, female reproductive systems, GIT, heart and big vessels, lungs, pancreas, prostate, urinary tract, ureters, bladder, and urethra are clinically insignificant. These are the organs involvement in leprosy, and those marked with red arrow, those are clinically significant. Those with yellow, those are may be significant. Those with yellow, those are clinically insignificant. Bones, joints, and muscles. There are two types. Involvement is through two types: specific due to direct invasion and non-specific or indirectly affected. And the specific are due to direct invasion of Mycobacterium leprae. Bacilli deposits, bacilli, bacillary deposits, bacillary deposition within the bone and feeding vessels leads to osteitis, periosteitis, lytic lesions, and bone cyst in the phalangeal bones. Non-specific are most commonly affected indirectly and includes osteomyelitis, osteoporosis, atrophy, and absorption of bones. They result from the impairment of sensation, repeated trauma, trophic changes, and restricted movements. Paralysis and weakness or weakness of the muscles cause a tissue atrophy and osteoporosis. Asymmetrical muscular involvement may lead to deformities and disabilities and contribute significantly to disuse atrophy. In the hands, slow resorption and atrophy starts from distal end of the terminal phalanx and proceeds proximally. In feet, both the tarsals and metatarsals are involved. The metatarsal thinned out distally, referred to as a penciling or stucate candy stick appearance, and tarsal disintegrate. Facies leprosy is a triad of atrophy of the nasal spine causing nasal collapse, atrophy and recession of the maxillary and alveolar process resulting in loss of teeth, endonasal inflammatory changes. Joints involvement. It is a chronic insidious onset arthritis. Small joints of the hands and feet in symmetrical manner. An acute arthritis is due to during respiratory episodes. Neuropathic or Charcot arthropathy. Impairment sensation of joints, mainly weight bearing joints and surrounding tissues. Nails. Nail changes are more extensive in multibacillary disease. And findings are dystrophy, longitudinal melanonychia, longitudinal ridging, subungual hyperkeratosis, striae, pitting, leukonychia, and Bowes lines. Coming to reproductive system, in male, epidermoarchitis, oligospermia, testicular pain and swelling. During type 2 reaction, inflammatory exudates suddenly appear in those foci, resulting in the testicular hypofunction. Seminiferous tubules are obliterated by hyaline deposits on Leydig cells, and final stage is fibrosis. The atrophy of exocrine portion results in aspermatogenesis, leading to sterility with no loss of sexual potency, whereas atrophy of the interstitial cells, Leydig cells, which occurs late, affects the production of testosterone, causing impotence, and the bilateral testicular involvement is common. Marked reduction in male sex hormone, testosterone, resulting in impotence, reduction in testicular volume, altered hair pattern, lack of testicular sensation, and gynecomastia. Mean blood levels of gonadotropic hormone FSH and LH are raised, while that of testosterone is raised. Epididymis also shows a leprous granuloma. Female reproductive system is not significantly involved. Kidneys. It is a frequent finding. All types of glomerulonephritis have been observed in lepromatous leprosy, and particularly during the reaction. Functional abnormalities are proteinuria, microscopic hematuria, granular, hyaline, and red blood cell cast are seen. Biochemical abnormalities are increased serum creatine, serum urea, altered distal tubular functions, decreased GFR, and amyloidosis is in up to 30% of the cases. Coming to endocrine abnormalities, adrenals have been found to be involved through, but no functional deficit manifest clinically. Adrenal crises occur during the reactions, particularly type 2 reactions. Decrease in blood pressure, hypoglycemia, increased potassium levels. Sudden death may also occur. Granulomas in the cortex as well as medulla, mainly around the corticomedullary junction. Coming to lymph nodes, bone marrow, and spleen, reticuloendothelium systems get involved early in the course of the disease. Lymph nodes. Clinically observable enlargement of lymph nodes occur during the reactions. Lymph node involvement is more widespread and generalized, affecting even visceral nodes. In tubercular leprosy, lesions with foci of epithelioid cells and granulomata patchy fibrosis without caseation. Lepromatous leprosy, lepra cells in the reactive lymphoid background. Biopsy specimen shows the involvement of both the cortex and medulla by the bacilli-laden foamy macrophages. In bone marrow, aspirates from lepromatous leprosy patients, lepra cells increased in plasma cells, leukopenia due to bone marrow infiltration. Late clearance from these sites. Bone marrow continues to show organisms even when the skin smear have turned negative after the treatment. Spleen. Diffuse infiltration of the sinusoids with foamy macrophages and lepromas in the red and white pulps. Thickening of the walls of the medium and small sized arteries due to amyloidosis. Central nervous system. Fifth and seventh cranial nerves are well known to be affected, but the brain and spinal cord are said to be escaped from the infection. Perceptive deafness of the cochlear type has also been reported. The subclinical phrenic nerve involvement has been documented. In lepromatous leprosy patients show the vascular changes of motor neurons of the medulla oblongata and spinal cord. Coming to cardiovascular system, autonomic nerve supply may autonomic neural supply to the heart may be affected. Dysautonomia. Involvement of the vessels has been confirmed. Smaller vessels has been confirmed. The vessels get infiltrated by Mycobacterium leprae during the phase of basilemia. Special stains has demonstrated the presence of organism in all the three layers of the vessel wall. All types of vessels, including arteries, veins, capillaries in the dermis as well as the subcutaneous tissue, have shown infiltration. Histopathology, homogenization of the vessel wall, and fibrosis. Well developed granuloma in the intima of a vein distort the lumen. Leprous phlebitis of external jugular vein show the extensive fibrosis, tubercular granuloma with acid-fast bacilli positivity, and also in nervosum. Hematological and serological. Low level of hemoglobin, iron, serum albumin, and raised ESR and serum complement levels in lepromatous leprosy patients. Chronicity of lepromatous leprosy patients and formation of immune complexes or autoantibodies cause for false pos- false positivity for anticardiolipin antibodies and based serological test for syphilis, Wassermann test, rapid plasma reagent. Lupus cells can also be seen. Anti-spermatozoal antibodies are often present in blood of lepromatous leprosy patients. Other antibodies are antimitochondrial antibodies, RA factor, ANA, anti-single stranded DNA antibodies, anti-neutrophilic cytoplasmic antibodies, most commonly C-ANCA, lupus anticoagulant, antiphospholipid antibodies, anti-beta-2 glycoprotein, and antithrombin antibodies. This picture showing the lupus erythematosus with positive antinuclear antibodies, fever, fatigue, arthralgia in man admitted in medical ward. As a lupus erythematosus with positive antinuclear antibodies, showing a malar rash in first picture. Eruptions appeared a week later, and slit skin smear revealed acid fast bacilli 3 plus with a history of discontinued incomplete anti-leprosy therapy 5 years ago. Most of the systemic complications and their disfigurement sequelae can be prevented by early diagnosis and treatment. Thank you.